And my name is Sushil Garg, as Venkat said. I work at Mayo Clinic as a gastroenterologist and pancreatologist in health system. I would like to welcome you all for today's event. We are honored to have Dr. Palermo as a guest today in the field of anesthesia and pain medicine. Dr. Palermo is a professor of anesthesiology and pain medicine at University of Washington. She holds a prestigious Hughes Catherine and Blake Endowed Professorship in Health Psychology. She also runs a sleep lab and has worked in management of chronic pain and preventing pain. We are honored to have her here to help us understand anxiety and depression in chronic pancreatitis. I would like to invite Dr. Palermo to teach us about this complex problem. Dr. Palermo, floor is yours.
Great, thank you. I'm going to go ahead and share my screen. All right, are you able to see my slides?
Yes.
Okay, terrific. Well, thank you so much for the invitation to speak today. I'm a clinical psychologist by training and have done work for many years in pain management, both in children and adolescents, as well as in adults. And so I thought today I would focus on a combination of screening for anxiety and depression, but also really talking about how that is interwoven with the pain experience for many of our patients. All right. So I'm going to talk a little bit about comorbidities that are common in recurrent acute and chronic pancreatitis, talk about screening for anxiety and depression, and then identifying treatment strategies that can address pain, anxiety, and depression. So we know abdominal pain is incredibly common for patients with chronic pancreatitis, and that 80 to 90% report pain. There's a large subgroup of patients for whom the pain is severe and constant. And this is true across the lifespan. We see the same thing in pediatric patients as well as in adults in terms of the frequency of pain. We also know that clinically significant levels of anxiety and depressive symptoms are very common, occurring in 40% of patients with chronic pancreatitis. Wanted to just show a recent paper that came from the PROCEED cohort, where we worked on really looking at the relationship between chronic pancreatitis pain and aspects of physical, mental, and social health. And I want to draw your attention first to just the pain experience. As mentioned, many individuals have severe pain. So in this cohort, 59% reported severe pain. And then if you look at the constancy of that pain, you can see a large subgroup is reporting constant pain. The middle panel really shows the relationship between having severe and constant pain experiences and the experience of quality of life. And so you can see for those who have severe and constant pain, we see the most negative quality of life compared to those with milder levels of pain or intermittent pain. And then importantly, when we look at clinically significant psychological and behavioral symptoms, we see a pattern where having severe or constant pain is associated with having the most problems with psychological and behavioral symptoms. And this includes having low physical activity levels, having high levels of sleep disturbance, and having high levels of anxiety and depressive symptoms. So these comorbidities are important. They're overlapping and are important to think about as a constellation of symptoms. So worldwide, 1 in 5 adults experience chronic pain, and 1 in 15 experience a pain that significantly interferes with daily life. So we often refer to this as high impact chronic pain. And among those with chronic pain, 1 in 2 actually experience clinical levels of anxiety and depression. So outside of pancreatitis, thinking just about general chronic pain, we know that the overlap with anxiety and depression is quite large. So there's lots of symptoms of depression that are important to consider in this patient population. Some depressive symptoms are more obvious than others, and I think that's why I wanted to put this list here, is obvious symptoms of sadness, of hopelessness you might think about with depression, but there are also less observable symptoms of depression, such as difficulties with concentrating and loss of interest or pleasure in activities that really characterize depression for a lot of individuals. Anxiety is also incredibly common and can overlap with depression. So we know that there's there can be an overlap where someone has symptoms of depression, but also has an experience of a major anxiety disorder as well. Most common form of anxiety disorder is called generalized anxiety disorder. And this is anxiety that can interfere with life. It's like a persistent feeling of anxiety. Some of the symptoms are listed here: feeling restless, having difficulty concentrating, being irritable, difficulty controlling feelings of worry, and having sleep problems. And you can see some of them overlap with symptoms of depression, which can make it sometimes complicated to understand whether a patient's presenting with anxiety, depression, or both because of this potential for overlap. There are a number of measures that can be used to screen for anxiety and depression. This is an ultra brief screen. This is a 4-item measure, the PHQ-4. You may know that the PHQ has other versions. There's the full version for depression is called the PHQ-9. The full version for anxiety is called the GAD-7. But the nice thing about this 4-item version is that it really gives you a quick screen that helps you understand whether someone is potentially having significant symptoms of anxiety or depression. Very easily scored, very easy to integrate into a clinical setting and be able to engage in screening of a population. For research, we often use extended symptom measures. So we might use measures that look at a broader range of both depression or anxiety symptomatology. And also know that there's measures that are more specific to pain. So we can also measure anxiety related to pain specifically, as well as other constructs such as pain catastrophizing that help us understand other perceptions that are related to feelings or cognitions about pain. So there are lots of problematic ways of thinking that interfere with pain management. Catastrophizing is a area that has received a lot of research because it is highly predictive of pain across a huge number of disorders, including both acute and chronic pain conditions. And catastrophizing really is defined as this tendency to blow circumstances out of proportion. And when we think about it in pain specifically, it's made up of 3 components: rumination, which is not being able to get rid of thoughts about pain; magnification, which is really thinking something is overwhelming; and then a feeling of helplessness about pain. And we know that higher pain catastrophizing is related to higher disability, higher anxiety and depression, as well as lower quality of life. So this is often a target of psychological interventions that we deliver for pain management. We're really trying to help people think about pain in a way that makes it more solvable and easier for them to cope with. So depression and anxiety sometimes needs a separate treatment. It's not something that we can do as part of their pain management plan, but both conditions can be treated with medication and psychotherapy, often a combination of the two. And I think the point I just wanted to make is really that it just takes time. Antidepressants take time to dose escalate and to see if someone's going to have a good response. And very often, additional support is needed while someone is trying out different pharmacological interventions. So very often the combination of medication and psychotherapy is helpful so that person can get support and learn some skills while they're still maybe working through some different medication options. So cognitive behavioral therapy is a major type of therapy that we use for anxiety, depression, as well as for pain management, that's really based on helping people to think differently about their condition and symptoms and get rid of sort of faulty ways of or unhelpful ways of thinking. And they learn different behavioral patterns. So learning ways to cope that help them relieve symptoms and to have the ability to be more effective in their lives. So often this includes things like teaching someone effective ways to use relaxation in their daily life to manage stress, anxiety, or pain symptoms. It can also involve teaching cognitive interventions where we teach people better ways of thinking about things so that they feel more hopeful. It also includes very practical things around sleep habits and activity engagement, helping people set goals for their daily life. So one of the big aspects of CBT focuses on changing this unhelpful cycle of symptoms. And this diagram just kind of shows what that is like, where someone has unhelpful thoughts, and that might change the behavior that they engage in. So that if they have a thought that they're going to have a lot of pain from this activity, they might choose not to engage in that activity and to rest instead. But unfortunately, resting sometimes increases the experience of physical symptoms, and then leads again to this cycle of having thoughts that you're not able to carry out everyday activities when you're in pain. And so we really help people both get exposure to being able to do a little more in their daily life and being able to see that they're able to tolerate it with good pain coping skills, and how it can really reduce this sense of helplessness and help to improve overall well-being. We also focus on building pain coping skills. So there's a lot of ways that people can learn to integrate some coping skills into their daily life, both as a form directly of managing pain exacerbations, but also of dealing with increased stress or increased anxiety. And we usually explore several of these strategies with patients and find one that they can use well and that integrates well into their daily life. There is a lot of evidence for psychological therapies for chronic pain. Most of these are CBT based, and just showing a few major reviews that have been done both in adults as well as in children. There's about 100 studies in adults that show small to moderate benefits on reducing disability, on improving mood, and improving catastrophic thinking about pain. And then in children, we see positive effects on pain, disability, and anxiety from the same types of treatments. So good evidence base to support their use for management of chronic pain in a lot of different populations. And so my own work has really been focused on making these types of treatments more accessible. One of the problems with trying to find these types of interventions for your patients is that they're not often available in the community. So it's really difficult to access specialized psychological expertise in delivering pain management interventions. We know then if you send a patient to a pain clinic that has interdisciplinary care, there's often a very long wait list. They may be waiting 3 to 6 months for services. So the access problem is pretty big. And children have particularly poor access. There are even fewer specialized pain clinics that serve children. We know from population-based studies that only 5% of children actually receive psychological intervention for pain management. They're much likely to have access to other forms of intervention. And so really the take-home message has been that we need accessible options to provide this care in alternative ways. So we've explored doing this through internet and mobile delivered applications that teach the same pain coping skills that we would work with a person on individually in the office. So one of the things we've worked on over the past few years is adapting a program that we made for general chronic pain to be specific for chronic pancreatitis. And so we started with our pediatric program and adapted a program called WebMap, with making it specific to adolescents with chronic pancreatitis. And we've been testing that in a clinical trial that we're just about to wrap up that's been using the Inspire network for recruitment. And then we took the same idea in our adult population, and we worked on adapting a general pain management course called the pain course for adults with recurrent acute and chronic pancreatitis. And we tested that in a pilot clinical trial. And I'm actually going to go back for just a second. And in our pilot study, we did find that we had significant changes in both pain and disability among adult patients who received the pain course compared to those who received a control comparative condition. And so it really was encouraging that this might be a good type of intervention to offer to this patient population. So we are now had put in a proposal for a larger randomized controlled trial testing our adapted pain course for adults with chronic pancreatitis, and recently received funding for that. So we'll be starting a much larger trial in the early part of next year, focused on recruitment through some of the PROCEED sites, as well as through the community, to really test the efficacy of CBT-based internet strategy in this population. So we're excited to get that launched and be able to offer this type of service to this population. So quick summary, we know that pain's a common problem in individuals with chronic pancreatitis across the lifespan. It's very often accompanied by comorbidities, including anxiety and depression. And I do think every single patient with chronic pancreatitis should be screened for anxiety and depression. As I've shown you, it can be done very efficiently in the clinic. But we know, just given the base rate of clinically significant symptoms, that it would be prudent to screen. You're going to have many people who need referrals for treatment. What's important when you start screening is to make sure you know where you can refer to, and that you've got those referral streams set up in advance so that you have a good way of offering services if you're going to implement new screening. But I do think when we're able to do this at the clinic level, it really helps us understand how we can address needs better. Psychological interventions, can help with anxiety and depression directly, but very often we're using them to deal with the combination of symptoms around both helping with pain management, but helping to reduce these comorbidities. And so they play an important role. Sometimes they play a more primary role in treatment of anxiety and depression, but sometimes they're really complementing pharmacological treatments, but are important to consider how best to integrate. And I am happy to take questions and wanted to leave some time for discussion.
Thank you so much, Dr. Palermo, for your talk. I learned a lot. I'm going to use some of your points to my patients. I think I haven't implemented the screening in my patient population, that I should start doing it actually. I always think that I was doing everything, that maybe not. I need to work on it. I will open up to the questions. I have one question, then I'll ask the rest of the group to see if they have any questions. I just wanted to mention that Dr. Singh's flight is delayed, so he won't be joining us. So if Dr. Palermo has time, so you guys can ask more questions. So my question is that most of patients with chronic pancreatitis, they also have addiction problems, from alcohol addiction or smoking or both. And there are certainly negative emotions associated with, either they don't have access to alcohol because they have pain, so they can't drink alcohol. And they probably have some anxiety and depression from the fact that they used to be, you still drink alcohol, or they used to drink alcohol, and there is like withdrawals and all that. How does that play part in the I mean, now they have a chronic pain, but they also probably had anxiety and depression to begin with, even though they didn't have pain in when they were, had alcohol abuse. How do you is that the same approach that you use, or is there a different approach for those set of patients?
Yeah, that's it's a really good question. And I agree there's other important comorbidities, and substance use is definitely also important to screen for and to figure out how does that play a role in the overall management plan. You're absolutely right. In adults, at least the rates of alcohol use are high in this population and should be a part of how we comprehensively think about their overall care. There's certainly interventions that provide support for alcohol and substance use that are important to consider. I think when you really talk about the overlap with depression and anxiety, that was, I want to just throw in there opioids too. We also know that initiating opioids can actually initiate a new episode of depression. So just something to keep in mind that these things are very, very interconnected, and which is why I think the monitoring and screening is so important, because when we do start someone on opioids, or even if they've been on persistent opioids, there's also a very high overlap with new depression symptoms. So I agree with you. I think these patients are complicated, and the more that we can look at kind of whole person health and think about how do all these things fit together in helping them manage their disease, I think the better.
And okay, do you in terms of, and this is was Dr. Singh's talk, but I heard him in one of the DW talks that my go-to pain management medication have been pregabalin that he prefers. Do you see that when patients are on, so what happens to I will talk about my own experience. We put these patients on high dose pregabalin. So, and then I'm very scared about like putting someone on SSRIs now, because now you have the interactions issues with the pain management. Is that something that you face in your practice? How do you manage, like when someone is already on 2 antidepressants and now you're like, you have to give them, either they are already on antidepressants, you have to prescribe them a neuromodulators, or the other way around?
Yeah, I'm unfortunately not able to answer medication questions because that's outside my scope, but I think it's a good question to think through. How are you going to address? And sometimes this is why really starting with psychological treatment of anxiety or depression is a good start if you're still working on what's the regimen going to be for their pain management. We have lower risk starting with psychological treatment for anxiety and depression, and can hopefully make a difference in some of this while you're working on medication options.
I'll let other people ask questions. Stop.
I have a question, please.
Yeah, go ahead.
So what I hear you talking about in the presentation was pretty much geared towards the psychological aspects of pain. I don't know, maybe I misunderstood, but that's what it seemed like to me. The pain, in the sense, at least in my mind, is it's also a physical. So is there any blend of the psychological treatments for depression and anxiety that help reduce the pain, those kind of treatments that you discussed, and blending that with an opioid treatment process I mean, that's the only exposure I've had is the opioid treatments. I live in a small rural community. There's medical facilities are limited in access. I go to the emergency room and I just get opioids and they send me home. I'm trying to understand how these two can come together, if they can come together, and help treating the overall problem of depression, anxiety, and the physical aspects of pain.
Yeah, absolutely. And I'm addressing the psychological aspects because that's the topic I was given. So as a psychologist, that's my wheelhouse. But you're absolutely, this is part of an overall care plan. And I think what's really hard is that, unfortunately, this part is not available in a lot of communities. And so it's really, most patients only have access to pharmacological treatment. But we really do think that the synergy that you can have between multiple treatments. So if we know that there are physical treatments that help with pain, there's psychological treatments that help as well as pharmacological. And really, in the best case scenario, patients would have access to all of these treatments. So I think, I don't want to suggest that this is the only treatment that would be delivered alone. It absolutely would not be, but we would love to be able to complement, the care plan for patients and be able to support management of anxiety and depression, because it's something that's often missed in the care.
I will ask one more question in the if the for the group. In the meantime, if someone is thinking about it, is there a website that people could use to find the local resources that, if there is a trained psychologist in the area who would manage they could refer to if they don't have anyone in the group, in their own group?
Yeah, that's a good question. There's not a general resource that would provide that specifically. However, there definitely are some ways to access some forms of psychological strategies online. So the pain course that I talked about is actually a resource that was developed at Macquarie University in Australia, but it's actually freely available online. There's another course called the Pain Trainer, also out of Australia, but is also accessible online. Those are both things that can be accessed, and they're not geared toward chronic pancreatitis specifically, but they are at least general chronic pain resources. In terms of finding therapists in the community, it is hard to, because there's not a way to search just for pain specialization. I think it's mostly through referral and in specific communities, but there is a website called Psychology Today that in every single community you can put in your zip code and you can see psychologists in your area. That there is some filters, so you can search for some different specializations, but they will be a little bit broader. Like, and you can search for anxiety and depression. They just don't have chronic pain as kind of a searchable field. But that's at least a way to see who are the psychologists in the community and try to get a sense of whether there might be someone with this expertise.
Yeah, thank you so much. Yeah, that's helpful.
So I have a question. I'm really not sure how to phrase this, but so the chronic pancreatitis patients, they have pain, but managing pain through psychological interventions can help them live with the pain, but it still does not solve the issue of the disease, which means the disease is getting severe with time. So how do you know that when to really intervene, or maybe do a surgical procedure, remove the pancreas, or have this person continue with the pain management? So what are the options there?
Yeah, I guess if you think about chronic disease management, and this is true for other conditions as well, the goal is really to improve the person's well-being. So I do a lot of work in sickle cell disease as well, and we have a similar types of strategies that we work with patients on, where the goal is really to improve well-being. We know we're not modifying the disease, but we are able to help people live their life more fully by learning ways to better cope. And it can reduce their pain level. There is not a direct correlation between amount of disease activity and amount of pain. There's lots of other variables that affect it. We know that, psychological factors as well as other things have a huge impact on people's pain perception. So it's complicated because it's not just that disease severity means there's more pain. We also see people with lower disease who have very high pain levels. So I think it's important to just keep in mind that building skills in a patient is always a good use of time, no matter when it is. And even if they go on to have future surgical interventions, they will have learned some things that can be generalized and might also help them with future recovery after procedures. So I think it's still a good investment of a patient's time to learn strategies and skills for pain management.
Thank you for that talk. It was very helpful. I'm just wondering, as a pancreatologist, definitely not trained in CBT, if there's one thing I could do in the clinic, if I'm seeing a patient and I had 10 minutes, there was one strategy in terms of low-hanging fruit, which might benefit the patient, and I didn't have immediate access to you or someone with your expertise, is there something that you would recommend?
Yeah, that's a really good question. And I think I'd probably say a couple of things. One, take 2 minutes and screen for anxiety and depression. Two, I would listen to your patient and make sure that they feel heard around how pain is interfering with their life and that you understand and want to help support them. I think that feeling of being heard, feeling of having someone validate you goes really, really far when you have chronic pain. And then I think the last thing, if there's a practical skill, it's really encouraging some regular engagement in daily life activities. So helping patients think about what is it they want to be doing, and are there small ways that they can take steps toward getting back to that. Sometimes there's a role for some other physical treatments like physical therapy and other things to help people be able to build back that activity, but just understanding what is it your patient wants to do, and are there some small ways you can get them moving toward that again, because then they can build on that. But they sometimes need to see that it's possible despite having high pain levels.
Anybody else has any other questions? I think that was an excellent question. That was pretty helpful. Well, I think that's it then. Tracy, anything else that you wanted to?
Well, thank you. It was a pleasure to speak with you today.
Well, thank you everyone for coming. We will close the meeting unless anybody has any last minute questions. Okay, well, have a good evening.